Thank you for joining us this morning. We're going to talk today about establishing quality tolerance limits, and it is a subject that has come to the fore fairly recently in terms of the clinical space. It is a well-established idea and practice in the GMP, good manufacturing practices space. So that's me, and our learning objectives today are to evaluate the requirements that propel the development of quality tolerance limits. They're quite a bit different than the GMP world. Define the quality tolerance limits and understand their purpose, and we're going to spend a good amount of time on that because it is critical to understand the difference between quality tolerance limits and key risk indicators. And then the next objective is to examine the protocol to identify critical processes that might impact subject protection and/or data integrity. So there's processes in the evolution of a protocol and its conduct that need to be looked at too to determine quality tolerance limits, if they do at all, if they impact at all. And then document the development process of QTLs. I'm going to start saying QTLs because it's much shorter. And how to implement the established QTLs, how to track and assess data to establish whether they are within the limits that have been established, how to respond when the QTLs have been exceeded, how to recognize the evolution of QTLs over the life of a clinical trial. Real important for us to recognize that QTLs are not static. And then how to modify QTLs depending on the circumstances that are encountered. And we'll have some examples of those. And then how to document to justify any changes to the QTLs, because we do need to show that we have addressed them and how we have addressed them, and if they have changed, why they have changed, and what they have changed to. So the cycle is develop, apply, and adjust. And we see this cycle through the clinical world in terms of clinical studies. And it's important to understand that, so a risk-based quality system is a cycle. It is definitely not static. Folks really need to understand that. So it's not just enough to say, this is what I think we should do and just go do it. Those decisions need to be continually reevaluated to make sure that you're getting the outcome that is desired through either process or the specific data that's collected, et cetera. So what made our industry, our clinical research industry, develop QTLs? Well, first off, EMA has instituted a new clinical trials regulation, Article 47, and it makes ICH E6, GCP, legally binding. And we're going to see a little bit further on in this Section 504 on risk control how that affects QTLs or how it comes about. And then also the new CTR, EMA CTR, in its discussion of implementation of risk-based quality management for a clinical trial, that implementation shifts from the judgment of a sponsor, so just pure judgment, to now a legal obligation, right? So now there's teeth behind ICH E6 in the EMA countries. And then the reference in E6 is Section 504, the risk control, and very specifically it speaks to determining a point where, if met, so that's now telling you that there is a lower limit and an upper limit, the ability to draw conclusions from the data is lost. So at what point is the data so compromised or is the data not enough that you cannot draw a conclusion from the data? So when will you lose power? When is data integrity lost? So as we move into slide number 6, to evaluate those requirements, E6 Section 507 discusses risk reporting. So it says that the sponsor should describe their quality management approach implemented in that trial and then summarize the important deviations, from the predefined quality tolerance limits. So it's the inference there is that you're going to do them. You're going to have QTLs, and any remedial actions taken are reported in the clinical study report, and that's in ICH E3 Section 9.6 of Data Quality Assurance.